Chapter 13 in R&M, we're going to talk about duplex scanning and color flow imaging of the lower extremities. Capabilities is going to help us determine the presence or absence of disease, categorize severity, and allows localization of disease. So it's going to help us locate where the disease would be in the artery. Readily identifies hemodynamically significant flow-limiting lesions with a diameter reduction of greater than or equal to 50%, and differentiates from complete occlusion. So basically it's going to let us know if there is a significant stenosis. Is it greater than 50% or less than, or is it a complete occlusion? A complete occlusion means the entire artery is blocked, zero flow is going through. It's going to help us determine the presence or absence of an aneurysm. An aneurysm is a dilation of the artery. We'll consider it an aneurysm if the dilation doubles in size. It's going to help us evaluate a bypass graft and, again, localize a stenotic lesion. A stenotic lesion is just a stenosis or a blockage in the artery. Limitations pretty much the same here. We can't see through dressings, skin staples, sutures, open wounds make it very hard to image. If patients are tender, you can't apply that pressure that you need to get a good image. Calf vessels on obese patients are very difficult to image. Calcified arteries can cause shadowing, so you just do the best you can there when you have these limitations. The important thing here is to know that it's not your fault. If there's a dressing, skin staple, a really obese patient, calcified vessels, there's nothing you can really do to help that. You do your best there and move on. You're going to have patient supine, hip minimally rotated externally with the knee slightly flexed. The arteries we're going to look at for lower extremity arterial exam are going to be the external iliac artery. Okay, listen. So we're not looking at that in our protocol now. But if you go to clinical and you're doing a lower extremity arterial exam and you notice the common femoral is monophasic or stenotic with a high velocity, I'm talking over 200, 300, 400, pause, slide up even higher into the groin and get a Doppler waveform of the external iliac artery. Again, the only time we will image external iliac artery for a bilateral lower extremity arterial exam is if the CFA is abnormal. So if the CFA is abnormal when you start, as in high velocity, over 200, or monophasic waveform, slide up into the groin more and get a Doppler waveform of the external iliac artery. At that point, if external iliac artery is abnormal or normal, you just note that in your report, let the physician know, and then they'll order a different test. Okay, so moving on down, the DFA, SFA, popliteal artery, PTA, ATA, perineal artery. And that's bilateral. We will use the 5 to 7 megahertz linear array transducer. The technique, we're going to look at the arteries in grayscale. This helps us look for plaque. So I know it's hard to appreciate now because nobody in class has plaque, but your patients in the hospital or in clinic are going to likely be older and have some plaque buildup on the wall. That's why we do a grayscale, to identify that plaque. Is the plaque fresh, like thrombus, acute, or is it calcified with shadowing, older plaque? We're going to look at the arteries in color. The reason we're putting color on and the reason I want you to make sure you gel your path and don't take your probe off is because you're going to follow the artery down in color in between your segments that you Doppler and check for any color variations. You know, sometimes when your color gets those hues of green, yellow, blue, that can indicate a stenosis. Sometimes you might not see the plaque, especially if it's fresh plaque. It can be sort of dark. So that color will help you indicate maybe a blockage with the different hues. Because I have a picture at the end, so you'll see that. It might be this slide or this PowerPoint or the next. I have a picture to help you appreciate that. But anyway, that's how we assess the arteries in color to look for flow patterns, check for stenosis. We take peak systolic velocities at each level. We check to make sure they're triphasic or biphasic. Triphasic is normal. Biphasic, we consider normal in our lab. Most places might not, but we put triphasic and biphasic into a category together, and we just know multiphasic. So I'm going to call both of those normal, tri and bi, normal. But monophasic, no doubt, abnormal. And that's what we're checking for, the peak systolic velocities and what the waveform looks like. When there is a greater than 50% stenosis, we need to pause our protocol. If you are scanning down the SFA and at mid, you get an extremely high velocity with, your color, and you can see plaque, your color hues are different, you are going to pause your protocol. You're going to get a Doppler velocity prox to that point. So move up just proximal to that stenosis. Prox stenosis, stenosis Doppler, post stenosis Doppler. So when you see a stenosis, again, you pause and you Doppler before, at, and after the stenosis. Perfect. This is just what I wanted. So you can see a picture here in grayscale. This is the right prox popliteal artery. On the left, it's grayscale. Honestly, I can't really appreciate that plaque so much. Maybe I can. But when I turn the color on, look what happens. That color really gives it away. You can see, to the left on the color box, where the color starts to get yellow and blue. And then after that, the color's blue and sort of chaotic. So that is a stenosis right there. That would draw my attention to stop. Okay, let me Doppler that. You're going to get probably a really high velocity right here. Okay, I'm going to go before that in Doppler, at the highest velocity, and then after. Perfect. So what I did here, top left picture, right distal SFA. So I slid up to the distal SFA and I did prox to stenosis. And then the middle picture is the right prox pop at the stenosis. See right there, I placed my Doppler where that color flow was changing and I got a velocity. The velocity in the distal SFA was 30.3 centimeters per second. It increased at prox pop to 504 centimeters per second. That's a major stenosis. This is a severe blockage. And then what I did is I slid down to right prox pop distal to stenosis, and my velocity dropped to 148 centimeters per second. So that proves to the physician, we've got a problem here. We found the problem in the prox popliteal artery. Okay, bypass graft. So basically what happens is in most places, in our office, in most places, when a patient has a blockage like the one I just showed on the previous slide, they will go to an angio, and it will that blockage will they'll attempt to fix it through minimally invasive ways. They're going to try to put what's called a stent in, or try to go in and just take out that plaque or push the plaque up against the wall. There's a few different things, minimally invasive. If that doesn't work, the patient's going to have a bypass graft if they're available. The only problem with getting a bypass graft is it is a very intense surgery. You have to open up the patient's leg, and they're going to end up in ICU for a few days. They're very successful, but it is a very hard surgery to go through. The patients will tell you it's a lot harder than they thought. It's just not easy. So if the physician is unsuccessful in treating this blockage with a minimally invasive technique, you'll get the bypass. Bypass what it will do is it will plug in, they'll go and plug into the artery before the stenosis, run a hose or a vein around the stenosis, and plug in distal to the stenosis. So there are two types. You can have a synthetic graft, a PTFE. That is a foreign material that they will hook in to bypass the stenosis. So they'll hook it in. For the previous case, what they would do is hook it in like somewhere maybe mid-distal SFA, bring it around the pop, hook it into distal pop after that stenosis or proximal PTA, and the flow in the artery will route around that stenosis. So it's basically if you're on the interstate and there's an accident, it's like you getting off the exit and taking a back road and then getting back on the interstate after the accident. Okay. Anyway, back to this different types. Synthetic graft is a foreign material that they use. Or they can take your saphenous vein and use that. They can actually turn your saphenous vein into an artery. Reverse saphenous vein graft is they will take the GSV out, get rid of all the branches, turn it around, and hook it in to your artery. That vein, the GSV, will become an artery. Or they can take the GSV, leave it in, they don't take it out, leave it in and just hook it in to the artery. Now, in order to use the GSV, which is preferred, because I'm told by our physicians that use the GSV, it's going to last longer as opposed to a graft. You tend to have more problems. If you use your own human material, your own vein, seems to last longer and have less problems, less complications. So, but when you use the GSV, it has to be a certain size. You cannot have an SVT or thrombosis in the GSV. They need to have it. Our physicians like it to be above 0.3 centimeters or larger. So, some people don't have a greater saphenous that they can use for those reasons. So in that case, you would use a synthetic graft PTFE. Okay, and I already talked about this. So what they'll do is for a bypass graft, they will hook it in above the blockage. So if for this case that we're talking about, the blockage is at prox popliteal, they'll hook it in to SFA. Your inflow artery will be above that. So you would label it common. All right? Common artery would be your inflow. Proximal anastomosis is where it hooks in, where they actually take the graft or the vein and hook it in. You'll be able to appreciate stitches. You'll see bright stitches. So that's prox anastomosis. And then the graft will measure a velocity proximid distal graft. Distal anastomosis is where they tied in distally on the leg or arm, wherever. Outflow, distal native outflow artery for this case would be below distal anastomosis. That would be probably PTA, ATA, perineal arteries, okay? So your normal Doppler interpretations here are going to be, as always, triphasic. Stenosis of native arteries. The stenosis peak velocity is compared to the pre-stenotic peak velocity, and a ratio is calculated. So an increase in velocity of 100% is going to give you a 2-to-1 ratio. That suggests greater than 50% diameter reduction. A pre-stenotic to post-stenotic peak systolic velocity ratio greater than 4:1 suggests 75% diameter reduction. A stenotic peak systolic velocity of greater than 400 centimeters per second suggests greater than 75% reduction, diameter reduction. Again, I'm going to say that again. The last bullet. If you have a peak systolic velocity in a native vessel, native artery, greater than 400 centimeters per second, that is going to suggest a greater than 75% diameter reduction in the artery, which means a big problem. After a significant stenosis, you will note post-stenotic turbulence. You'll be able to hear that too. It sounds, the best way to describe it is bubbly. It sounds bubbly. And you can see on this waveform, it's sort of jagged on the top. It's not really sharp peak. It's jagged, and then it just, the sound is hard to describe. You'll know it when you hear it. It sounds bubbly, but we call that post-stenotic turbulence. You find this waveform after a significant stenosis. An occlusion is when the vessel or the artery is completely occluded, which means no flow. There's zero flow. It's completely shut down with thrombus or plaque. No flow is able to get through. So when you see this, you know, I'm sure you've had, sometimes you'll turn the color on in lab and there's no color in the artery or vein. Well, you need to optimize before you call a vessel completely occluded. So what you need to do is turn down your color scale, increase your color gain, make sure, optimize your color, make sure you're right. There's another thing you can do that's called power Doppler. It is like color Doppler, but it's not going to give you red and blue color. It's just going to give you an orangey hue, and it's going to let you know, it's not going to let you know direction of flow. It's just going to let you know, is there flow or not? It's more sensitive than color Doppler, but doesn't give you direction. Always throw on your Doppler, pulse wave Doppler, to make sure there's no Doppler there. Before you get to an occlusion, so proximal to the occlusion, your Doppler signal is likely going to do what's called a thump, and it's exactly what it sounds like. It's going to be a monophasic, like boom, 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 boom. It's the blood hitting that vessel that's occluded. So you should get a warning sign before you come to an occlusion. If your SFA is completely occluded, when you go to Doppler common, you should get that monophasic boom, 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 boom. Your distal waveforms are going to be monophasic. A lot of times, say if your SFA is occluded, you come down to your PTA and there is flow there, monophasic flow. You're like, what's going on? How did that happen? Well, the body has made collaterals to feed the lower leg. It's still abnormal monophasic, but there can be flow there from collaterals. Bypass graft stenosis is a little different. When you get a bypass graft, we will scan them often to check for any changes. We compare to the current study to the previous studies. We're going to look for changes, a decrease of 30 centimeters per second. If the velocity in any part of the graft is less than 30 centimeters per second, that's a warning. Change in the waveform. Triphasic to biphasic. We really go tribiphasic to monophasic. And a decrease of ABI greater than 0.15. Okay. An aneurysm is an increase in diameter of 50% or greater than the native artery. So if the artery, all of a sudden you're scanning the SFA and it gets bigger, stop and measure before the biggest point and after. If that size doubles, that's concerning. You can also have a pseudoaneurysm occur in native arteries. We see this after procedures such as angiography, heart cath, or trauma. A pseudoaneurysm is going to have, it's where they've gone into the artery and made an injury. So it will have a neck and then a circle off of the artery. It's not going to be in the artery itself. It'll be a circle of blood outside of the artery. Put color flow on. You'll be able to note that on page 136 of R&M. Beautiful picture. Figure 1310 and 1311. 1311 especially has a beautiful picture of a pseudoaneurysm. There's a neck, and then there's a pocket of blood. Basically, they've made an injury in the artery. Blood is escaping through that neck into this pocket. So, intraoperative assessment, high-frequency transducer is going to be used to check for patency and evaluate any suspicious stenotic or turbulent areas. Normal findings, peak systolic velocity 45 centimeters per second, abnormal over 180, velocity ratio over 2.5, or low peak systolic velocities. Post-procedure surveillance of a bypass graft. If you get a peak systolic velocity of over 200, that's concerning. No diastolic flow, decrease in velocity, decrease in ABI of greater than 0.2. Clinically, if their status, if they're having leg pain, anything like that changes when they're walking or sleeping, they're having leg pain, or of low graft velocity of less than 45 centimeters